Good morning now. Today my topic of presentation is difficult LMA, but we will start with LMA from the beginning. LMA was introduced by Dr. Bryan. The history is very interesting. He is credited with invention and development of LMA in 1981. He developed this prototype by using Goldman nasal mask, which was fused with an obliquely cut endotracheal tube. His aim was to obviate the need for endotracheal tube placement and thereby reduce airway morbidity related to intubation. He tested more than 7,000 prototype on more than he tested prototype on more than 7,000 subjects before initial commercial devices, which was launched in 1988. He publicly demonstrated insertion of LMA into his own pharynx using local anesthetic. Classic LMA received wide recognition in short time and had major impact on and practice continuing the using of LMA. LMA approved for sale in US after 1993 till 2008. The patent was with Dr. Bryan. When patent was expired, then Cortex and Cobra started developing newer designs of the LMA. In 1983, first article of LMA was published in VJR. In 1985, CADS MD popularized its use in US. Slowly, commercial devices made available, which replaced endotracheal tube in the use as such in number of cases, and various modifications are done. So, what is LMA? It is LMA, also called as supraglottic airway devices, which are used to maintain airway patency and provide ventilation, just placing above the glottic opening. First, it was the first standard fixture in airway management, filling an IK between the face mask and the tracheal tube in terms of both anatomical position and degree of invasiveness. These devices sit outside the trachea, but provide a hands-free means of achieving a gas-tight air. Supraglottic airway devices are classified in different ways, but this is the simplified classification, which divides into first generation, second generation, and the third generation. First generation's devices are simple, low pressure pharyngeal seal, which may or may not protect the airway from aspiration. No specific design was made to lessen the risk, and it contains only airway tube. Second generation devices were specifically designed for safety, which had a gastric channel or drain tube. It has improved pharyngeal seal, and it also has integral wide block, which reduces the risk of aspiration and more efficacious in ventilation. First generation LMAs are classic LMA, flexible LMA, Cobra LMA, and laryngeal tube. Second generation LMA contains ProSeal LMA, Supreme LMA, iGel, and Sleeper. This is again the first generation and second generation devices with advantages and disadvantages. The third generation are equipped with the camera and fiber optic illumination to visualize insertion of the devices. Actually, third generation is a misnomer. It is second generation with additional feature. This is the only third generation LMA I have noticed. It is called as Busca LMA. It has attachment for the suction. It has white block. It has tube for manually curving the mask for easy insertion. It has large tubes for rapid gastric fluid clearance, advanced area opening, which provides superior patency of seal and increased protection against gastric overflow. Self-recoiling cuff, which produces effective seal with the larynx. It has advanced self-sealing variable pressure cuff. Expanding membranous cuff produces a seal which increases proportionately with increased airway pressure during positive pressure ventilation, and it has superior gastric reflux drainage, which is a large distal aperture, locates at upper esophagus and opens into some cavity for easy drainage of the gastric fluid, and thus minimizes the risk of aspiration. These are the different LMA sizes. This is a classic LMA. It ranges from size 1, 1.5 to 2.5, 3, 4, and 5. Now the uses of LMA, supraglottic devices are recommended as a rescue airway in cannot ventilate, cannot intubate scenario. It can be used during the procedures outside the operating room, radiology, MRI, radiation therapy, diagnostic and short therapeutic procedures in children, in cardiology and endoscopy, head and neck surgeries, pulmonary medicine and thoracic surgery like bronchoscopy, laser surgery of the trachea, tracheobronchial stent placement, and neurosurgeries. Now, role of LMA in difficult air. LMA itself has a role as a ventilatory device or as a conduit to aid tracheal intubation. In recognized difficult airway condition, we can prepare patient properly. Awake intubation can be done if failed. LMA as an intubation conduit or as an airway device. In uncooperative patient or unrecognized difficult airway patient, we can give general anesthesia. We can paralyze or not. Then we can try mask ventilation. If mask ventilation is achieved, intubation choices. If intubation fails, we can use LMA as an airway device. If mask ventilation fails, no emergency pathway, then we can use LMA as an airway device. If the intubation, we can achieve intubation through LMA as an intubation conduit also, and we can extubate over the dead style. Now, the ceiling pressures of LMA. The mean airway ceiling pressure is 19.5 to 21.3 centimeter of water. Now, the concepts here comes about the esophageal leak pressure and oropharyngeal leak pressure. The esophageal leak pressure is defined as the pressure which breaks seal between the cuff of supraglottic airway devices and pericuff mucosa, allowing penetration of the fluid into pharynx and oral cavity. Cuff or overinflation and external pressure on neck can impair sealing capability of LMA during sudden increase in the esophageal pressure. Now, the oropharyngeal leak pressure or seal pressure is a measure of sealing of upper airway by curved LMA or supraglottic airway devices. Lower esophageal leak pressure causes incomplete mask seal, which can cause air leakage and insufflation of air into stomach, which causes risk of gastroesophageal reflux, and the chances of regurgitation and aspiration increases. Recommended safe cuff pressure is 20 to 30 centimeters of water. These are different LMA sizes with the amount of air to be filled in the cup and the leak pressure achieved. With this is about classic LMA. Now, the troubleshooting LMAs. What difficulties we face while inserting LMA, the causes and the confirmatory test, and the solution for the problem. First one is the difficulty in negotiating the curve at the oral aperture. Causes may be disproportionate oral aperture, small oral aperture, inappropriate size of the mask, inability to open mouth fully. Confirmatory test is visual inspection only. The solution for this is insert correct size of LMA, deflate cuff prior to insertion, attempt lateral approach or opening of the mouth with the help of laryngoscope, PVC or gastric tube stent for the drain tube. Laryngoscope used bougie guided insertion. The second problem is the insufficient depth of insertion. Again, the cause is disproportionate oral aperture, short neck, light plane of anesthesia, malposition, LMA tip into the laryngopharynx, or insertion into the glottis. Again, confirmatory tests are visual inspection, gel displacement, thread test, soap membrane test. The solution is take proper size of LMA, deepen anesthesia. Further pushing in LMA will usually correct this problem, remove or and reinsert. Third problem faced is the migration or rotation of the bite block protruding the LMA. It is caused due to overinflation of the cup, herniation of the cup, accidental displacement, or posterior folding of the mask. It can be this problem can be solved with monitor cuff pressure, pre-insertion cuff integrity should be checked, proper fixation should be done, lateral approach or bougie guided insertion, fiber optic guided insertion, and again remove and reinsert the LMA. Fourth one problem is difficulty in passing a gastric tube. Causes are inadequate lubrication, selection of improper size gastric tube, malposition, and gross overinflation of the cuff. And solution is adequate lubrication, proper size selection, correction of malposition, and monitoring of the cuff pressure. Fifth one problem we generally face is audible, air leak, or poor ventilation. Causes are small size of the mask, herniation of the cuff, inadequate anesthesia, poor fixation, open upper esophageal sphincter, or malposition. Again, solution is the same. Take proper size of LMA, change the mask, deepen the plane of the anesthesia, ensure palatal pressure and proper fixation, positive pressure ventilation, and correction of the malposition. Sixth one problem is faced with LMA uses airway obstruction, inability to ventilate, back slow to fill up. Causes may be severe epiglottic downfolding, glottic or supraglottic compression, cuff infolding, reflex glottic closure. The solution, reinsertion with the maintained laryngoscopy or jaw thrust. Air should be withdrawn from the cuff. Take proper size of LMA. One size smaller may be tried for cuff infolding. Ensure correct cuff inflation. Deepen the plane of the anesthesia and muscle relaxation. High PAP without apparent cause. Apparent cause like obesity or COPD. Again, the causes may be malposition, light plane of anesthesia, or inappropriate size of the mask. And solutions are correction of the malposition, deepen the plane of the anesthesia. Singing patient. Next problem we faced with the use of LMA is singing patient. Air leak is heard, inappropriate size of the mask, light plane of anesthesia, malposition are the causes. Again, solutions are same. Correction of malposition, deepen the plane of the anesthesia. Like abdominal distension, regurgitation through the drain tube, laryngospasm, bronchospasm, these are the routine, commonly faced problems with the use of LMA. And the solution generally remains same, like deepen the plane of the anesthesia, correct size of the LMA, gastric tube insertion should be done properly with the help of lubrication. And for bronchospasm, fiber optic suction, correction of the malposition, and the bronchodilator should be used. Now the positioning of the supraglottic airway devices is categorized into three. Grade 1 is the optimally positioned supraglottic airway device. Grade 2 is the suboptimally positioned supraglottic airway devices. Now, LMA in pediatric patient. Early trials of pediatric LMA, the design was scaled down version of the adult LMA and not anatomically designed for the children. Moreover, it was clear that the range of available sizes was inadequate. Since then, improvements in the design and availability of the suitable sizes, together with the favorable clinical experiences, have led to the increasing use of LMA in the children. As the LMA can be inserted easily without the use of muscle relaxants and provide a secure airway, it is increasingly used where a face mask was previously used. It is seen to replace the tracheal tube in a lot of situations, as its use with controlled ventilation has also become accepted practice, mainly Procil LMA. The presence of drain tube, which helps to empty the stomach in the Procil version of the LMA, has set aside fears of distension of the stomach with gas during controlled ventilation, leading to impairment of respiration, especially in smaller children. The classic and Procil LMA are available in sizes 1, 1.5, 2, 2.5, and 3, which are suitable for children of various ages besides the adult sizes. Fast track and C-track are not available in pediatric sizes, although there are reports of their use in the older children weighing more than 30 kg. The sizes of LMA to be used in a child is decided by the weight of the child and is often written on the LMA tube close to the distal end along with the cuff volume to be used. Now, recent advances in the LMA. Recent advances done with following points kept in mind. The SAD should provide higher seat pressure, which due to improved seat material and designs. It allows easier intubation using regular endotracheal tube. It provides gastric access port to vent or aspirate gastric contents. It has a bite block incorporation. Some of recent advances, this is the C-track LMA. It is weightless, less than 8 ounces, and it is totally wireless and portable device. The viewer provides control focusing and the image adjustment. The battery provides 30 minutes of uninterrupted viewing, and it is a rechargeable device. It has a dedicated endotracheal tube with an atraumatic tip. It has anatomically curved airway tube with integrated fiber optic technology. Airway is fully autoclavable. It has a USB cable designed to record and upload LMA C-track images to your computer. Magnetic latch connector, which correctly positions and secure the viewer of the LMA C-track. It has 2 fiber optic bundle emerges at the distal end of the airway tube under the modified epiglottic elevating bar, which optimizes the light source and enables uninterrupted image transmission to the viewer while protecting the airway tube from obstruction and raising the epiglottis out of the way for an endotracheal tube to pass through. Next is the Ambu Aura Gain, which is disposable laryngeal mask. It is integrated with the gastric access channel for managing gastric content. The original anatomical curve ensures rapid placement, intubating capacity using standard ET tubes. Integrated bite absorption area prevents airway occlusion. It has pilot balloon, identifies mask size, and provides tactile indication of degree of inflation. Navigation marks for guiding flexible scope. It is immersive. This is gastro LMA, specially designed for the endoscopic procedure. It has connector, endoscope port, adjustable holder. It has bite block, airway tube, inflation line, and the cuff pressure wall. Endoscope channel of exit. It has cuff and the strap to hold. It has this cuff pressure wall has 3 color coding: red, green, and yellow. We should inflate the cuff till the green mark. If while inserting the LMA, if the cuff gets deflated, we can conclude while observing this the cuff inside this cuff wall gets deflated. So it is from outside only we can judge whether the cuff is deflated or cuff is twisted inside the oropharynx or hypopharynx. This is the laryngeal tube. It is blindly inserted. The laryngeal tube goes into the esophagus. It has a distal cuff which seals the esophagus. It has a proximal cuff. It stabilizes the tube and blocks the oral and nasopharynx. It has ventilation holes. When laryngeal tube goes into esophagus, the distal cuff blocks the esophagus, and the veins at the distal end of the proximal cuff veins allows the suctioning and the passage of the fiber optic bronchoscope. It has pilot balloon, 15 mm standard connector, which can be attached to the ventilator. It has drain tube. It has teeth marks, and both cups are high volume cups which adjust ideal to the anatomical situation. Next one is the eye gel. It also has a 15 mm connector which can be connected to any standard catheter mount or connection. It has proximal end of the gastric channel. Clearly displayed information is available on the eye gel. Size, weight of the patient for which we can use. It has a integral bite block, buccal cavity stabilizer, epiglottic test. The face mask of the eye gel is the mirror image of the oropharynx. It has non-inflatable cuff which is made from a unique soft gel-like material. It allows easier insertion and also reduces the trauma. Its distal end has the gastric channel. Now, can we define a best supra airway devices? It is impossible to define a best, as the term may be used to mean safest, most reliable for controlled ventilation, and the cheapest one. Because the context is variable, SCDs are used in different scenarios for different purposes, may be used in hospitals, outside the hospitals, or during cardiopulmonary resuscitation. Each use demands different performances characteristics. Now the take home message is routinely test cuff before use. Avoid lubricants on the anterior surface of the mask. Adequate depth of the anesthesia is required while inserting, also throughout the surgery. Avoid disturbing patient during emergence. Keep cuff inflated till the patient is awake. Anesthetists should aspire to improving the quality of ACD insertions. Know your options and don't hesitate to use it. Thank you.